again 100 to 60, and then there's your alarms. So SIMV can actually be a volume, but it can also be a pressure. You can actually trade it to a pressure mode. A lot of times it's, was it Truman? Most of the kids at Truman are under what? Pressure, right? They're more sensitive to what's going on in the pulmonary valve and giving that based on that, not so much the volume. So remember, you got pressure mode and volume modes, right? These are some of the windows where we're going to look at the waveform with no pressure support. Do you see the trigger? So there's two of them that there's no trigger, so it's providing, one's a mandatory ventilation, and then you can see where there's a trigger and then a synchronized one, and this is where they're synchronizing the breath to the next expected breath. Huh? Yeah. I'll be honest with you, most of the time, and if you're doing 911, most of your modes are probably going to be assist control. Because the things you're wanting to do is you're wanting to start ventilation. You want to have it preset, then you go in and find your ideal. You can make your adjustments there based on your volume and PEEP, and then function in that mode. Now we can move into our constant positive pressure, which is CPAP. So if we look at this mode, you can actually see CPAP parameters. In this part, PEEP is CPAP. So see where it says CPAP right here? That's your PEEP. So don't look for PEEP anywhere else. It's right here, and it's 10. They just set it at 10, but here, as an adult, it's set at 5. I think I took the picture there when I had it set at that value. Trigger is P, which is basically setting at 2 centimeters below baseline. That's how it triggers that, or 1 to 5 liters a minute. Termination, again, 50%. O2, it's defaulted at 100, but we can go to 60. Apnea alarms at 20 seconds. Then we get into tidal volume apnea backup and rate backup here, which is actually going to take you to assist control once it goes from backup. And then you can see the calculated piece, and there's your IE ratio. It's set at 1 to 2. And then your alarms right here. So the thing is this is just like what you have on the truck, but probably measuring it a little bit more, efficiently, because you actually have a value that you're looking at here rather than a flow. So that's going to be a nice piece for you. And if you're wanting to, you have the ability to run this at 60% rather than 100%. So providing the same pressure, which is really what you're pushing for on this patient, if they're definitely like a CHFer, right? And then use your nitrates appropriately. But, yes?
You have to write all those settings down when you're working it, too, because when you go into, remember I called you on that on the ventilator section of it, when we got to 2,000, there's only like 2 questions you have to answer, 2 fields you have to fill in on that new chart.
Oh, yeah.
Mandatory deal.
Uh-huh.
If you don't write all this down, you're going to be screwed when you try to go do your report later, since this doesn't download. You have hell remember finding all those numbers.
Take a picture of my vent setting.
I never think about pulling out my phone and take pictures and then just to show me.
Is that what you do?
Yeah.
Yeah.
Yeah. You're definitely going to have it, because you have to fill out every one of those has a column in that thing.
Yeah. Yeah. Well, and so we'll have I'll definitely have in your report piece for you to provide mode, rate, volume, FiO2, and PEEP. Yeah. I don't know. So, but going back to this, PEEP 10, no pressure support yet, so that's blank, and then the rest of this is what we're looking at. This is what you're used to using all the time. But then we're going to move into this one. Now this is what you all have known as BiPAP, right? But what is CPAP pressure support? CPAP is providing the continuous end expiratory pressures at the end of a respiratory cycle to help distend and keep the alveolus open and recruit alveoli for oxygenation, right? We know that we can see it on the screen because it's going to come off the baseline based on how much you're providing, right? That's that constant pressure. This with pressure support is whenever it senses you taking a breath, that trigger, that dip, it's actually going to give you the volume, or not the volume, the pressure, because this is a pressure mode. This is going to give you the pressure that you need, and you're going to sense this this afternoon when you have that mask on. You take that breath, it's going to breathe for you, and it's going to give you what you need in that pressure. So what's interesting is sometimes if you're actually doing an interfacility, what you'll say is they'll go, well, I want this to be 24/10. That's the order they'll give you. And you go 24/10. 24 is the total with the peak and the PIP, and the basically with the constant pressure and then the inspiratory pressure combined is the 24. But you have to subtract that total from whatever your PEEP is. And that number, so if you turn around and they gave you 24/10, which means peak paw pressure is 24, CPAP or PEEP pressure is 10, subtract 10 from 24 and you put 14 right here. 14 and 10 give you 24. And that's, no, you have to do that. You're going to have to do that, okay? Because it's wanting to know what you want a steady pressure at, and when it triggers, what's the flow, what's the pressure going to go to. And on this particular setting, we have it set for 24. So you have to subtract the 10 because that's already there, and 14, and then the 10 and the 14 give you that total. Because remember, we're building on it. So you'll see that line, and then you'll see when it actually gives that breath, and it'll go up to that level, that pressure. That is how, and you'll ask yourself, okay, so what type of patients are these? Well, you've seen them, you've transported them, but at some point you're going to be using this in the field on your 911 calls. And so you have to go, well, when will I use it? When do I use CPAP versus, the CPAP pressure support? And I think it's based on your acuity of your patient and how well they're doing. If you start them on CPAP and they're like, oh, this is great, I'm feeling better, and you're seeing better results, then I'm fine there. But if you got one that's really tired, sick, and obviously their respiratory effort's not there, maybe their drive's there, but they're just not getting the volume or that they need, then you can actually go to the CPAP pressure support, and it's going to assist that, and you might actually prevent this patient from having to be intubated. Okay, so, and guess what? Today, you'll be on it. You'll be on it. You'll feel it. You'll make the adjustments so you'll know where it's at, and you'll learn some side effects too, or some things that you're going to have to change in your assessment when they're on there. Where CPAP, you can somewhat talk when they're on that mask and hear them. When they're on CPAP pressure support, every time they they say something, it gives them another breath. And they're like, and then they're freaking out, and you're trying to calm them down. So it's going to be more of yes and no answers, when you're asking them questions, and say, don't talk, just, because it'll freak them out. And if you already have somebody that has anxiety, because I didn't realize how many paramedics have anxiety about putting masks on their face. But last couple of classes, I got some that have that. So, and then some don't care. But so if you have anxiety, you got to express to your patient how they're going to actually work through that. Okay. So same thing. The windows are the same. You can still see the tidal volume. There's your peak pressures, and there's your O2 at 100. Yeah. And what happens if they stop breathing in this mode? It goes right back to what? Assist control. Good deal. There's CPAP with pressure support. You can actually see the CPAP waveform. Steady pressure, right? The baseline there, and this is them breathing on their own. And then here's the trigger. And they gave them the airflow and then the steady plateau there where we're getting oxygen and then exhalation. And then same thing here. This is your flow, which is just gases that are flowing, but this is more of your PAW that you're looking at. And we don't mess with this one. This is another more, it's not BiPAP. It's similar to SIMV with pressure control. They call it PSIMV. It's an optional pressure support ventilation. So this is a pressure support mode. And so you wouldn't start this or initiate this on a 911 call. This would be more of you doing one on an intrafacility. And you would actually have to get with a respiratory person to know what their values are for that pressure. Here's another mode. This is CPR mode. CPR modes consist of timed chest compressions, audible prompts, coupled with some automatically delivered breaths on an intubated or a patient that has a mask. You'll see the display that would give you those options. And definitely gives you prompts for with your metronome for performing CPR. So in this one here, you can actually see that you got, tidal volume here at 500, nothing on pressure support, and here's your alarms here. When we go to it, you'll actually see here that there's the mask or intubated. So asynchronized to synchronized, right? You're going to hear this, and you're going to hear a lot of alarms and metronomes going off. This can be somewhat annoying to some people, not want to have all that stimulus. So if that's the case, you can actually go to the assist control mode and turn off the PEEP, turn off the trigger, and set your pressure max at 60, your Pmax. Which is right here, which is already set at 60. But if it's not, you want to go do that. And this will give you the same as the CPR mode without all the bells and whistles. What time is it?
10:30.
Oh, wow. So we talked about medication, right? So there's our medications for our post-intubation management. And as John said, be prepared to give them ketamine right here, 2 milligrams per kilogram, and you can give that every 5 minutes. And then, of course, you have fentanyl over here as long as the systolic pressure is greater than 90. But I'm going to tell you that I think we under-sedate our patients because it's based off of your interpretation of your comfort and not the patient's, because they're not moving or but you have all kinds of warnings that are coming up that's telling you that the patient's level of consciousness is coming around, and I watch it a lot of times when I'm reviewing, like, I see blood pressures going up, I see heart rates going up. And then when I talk to them and I say, well, did you give that ketamine? I know because they called, and they asked questions, and I told them, and then they said, oh, no, they did just fine. I was like, yeah, you probably could have given it once or even twice, between here and Marshall, with some more ketamine, because you're averaging about a 15-minute, 20-minute transport. It would have been beneficial for that patient to get it. Even though you were happy with it, I think the patient could have benefited from it. So I think we need to be a little bit more progressive with our sedation and the post-intubation management.
They had one 68 minutes, wasn't it?
Yeah, from north of Emory all the way down to Tyler.
And the surgeon was pissed off because I'd given 500 mics of fentanyl to the patient, but I had him for an hour and 20 minutes.
Yeah.
I had him for an hour and 20 minutes, and I even called med control. Said, hey, I'm going to go ahead and give him another 100 mics as a pressure and a pulse rate increase. You can see it, clearly see it then he'd start climbing up, even with fentanyl again, he'd just fall right back down. So.
You know what another good indicator of your patient's sedation level? Your alarms. You're probably more apt to have high pressure alarm indicators with the patients that's coming out of sedation because of either bucking the tube, fighting, any of the coughing or whatever. I can tell you that if you turn around and you keep properly sedated, you're going to have a much cleaner report and an easier patient to manage.
Yeah, it's a whole lot easier to bag, everything.
Yeah.
Yeah, but that surgeon went nuts. He was still in surgeon and mother. Flip out. How much fentanyl did he?
Yeah, he wasn't very
Why'd you
happy.
give so much fentanyl? Keep him down for the last hour and 20 minutes.
Yeah, we couldn't fly. It was
Yeah, we
raining.
just pouring down rain. We wouldn't have said nothing if we come in with a little jump.
Right, we should have had him.
Yeah. That's what we need to issue, onesies, all right?
No, thank
Bernard, do you want a onesie? All right. So medication, right? Post-intubation management. Be more progressive with it. Keep your patient sedated. You'll be a happier medic and a happier patient, and you won't have a bunch of alarms because I tell you what, you get alarm fatigued with all that stuff going off, and you're going to go, oh my God, how do I stop this? And sometimes it's as simple as sedation. Yeah, or they open eyes and look at you. Yeah. Then you're like, oh, I might be behind the 8-ball here. Here's some troubleshooting. You'll actually see some of these pop up, such as a bad mask seal, low PAW, that's low airway pressure, high PAW, high pressure. You can get all these blocked airway. This apnea alarm, you'll see that one pop up quite a bit because we'll be playing with it, cause apnea, and then it'll shoot over to assist control. Another one that will happen is you'll see this one. It says low O2. Pay attention to it because when that pops up, you don't have much O2 left. And you need to be thinking, do I have additional resources? On the old one, yeah, because it's restrictive. It's not giving you the full value.
Well, that and the thing, it wouldn't even work, man. The apnea alarm, everything went off when I tried to hook up. 3 different times I tried to hook that ventilator up on the whole.
Well, think everything you're gauged at is at 55 to 60, and you're functioning 10 pounds of pressure less than that. So you're already behind the 8-ball, and so everything's screwing up because it's pretty sensitive.
Look at the CPAP we have right now. You're like, give me that throwaway piece of garbage and get this high dollar thing out of my face. It's driving me nuts.
Right. Oh, I get it. So make sure you'll actually have these. These are the things that I think that I'll make this PowerPoint available to you, and we'll make sure education actually laminates a lot of these troubleshooting. The ideal weight one, that's good. And then the abbreviations, I think that this is just good for you to kind of look at, but I'm not going to go through all of it. We've hit on quite a few of these.
When you send them to us, don't make them blurry.
Hey.
I said, hey, is that blurry or is that my eyes going bad?
Yeah. Well, see, it's like you're blurry to me right now, but now you're closer and blurry. So, hey, in summary, when all this fails, use your BVM.
Yeah.
Don't forget that, right? I'm just going to tell you, but it's use your BVM. You can use it with PEEP if appropriate, like they're not in cardiac arrest. Always use dope as your mnemonic to treat your problems, okay? Don't think that it's always got to be equipment because you're going to miss the big deal, the big picture if you go to equipment every time. That's the common thing that I see where people think it's an equipment issue. Go back and look through. So displacement, it could be the tube displaced, removed, right main. Obstruction, it can be occluded, mucus plugs, all those different things, right? Pneumos, right? So, and use those to help you problem solve the scenario that you're in and get through it. Probably the biggest one you're going to have is suctioning and mucus plugs. All right. So what time is it now? I'm early. So what time is the next thing?
Fine with that.
11?
Fine with early.
11:10. Oh my gosh. Questions. This is question and answers. What?
So, on this ventilator to get your plateau pressure, are you gonna hold your manual inspiration button and it'll give it to you?
You can.
Okay.
You can.
What'd you say? I was like, that's only, yeah.
But I mean, you don't want to do that every time.
No, yeah.
Yeah, I think that you're looking at your volume, then you look at your IE ratio. I think that, like I said, the driving things I always say is that if you have a patient that's air hungry, they're starved, give them volume.
Yeah.
Volume's going to, then you can wean them down once you get them past the crisis, right? And hopefully bring them back down. Huh? I didn't hear it. There was another conversation. Oh. So, good deal. Well, what do you think about it now? Those are the modes. It's fairly simple, and if you're still kind of going, I don't know, wait till this afternoon when you get to work with it. Like I said, we'll be in 3 smaller groups. You'll have 20, 30 minutes, I think, somewhere around there for everybody to work through and mess with the settings. Well, hey, John, y'all go to the restroom, come back in here, and we'll wait for them. Have a little free time then.